We have two lunch symposiums. In room A, we'll focus on respiratory syncytial virus prophylaxis. In room B, we'll focus on novel pneumonia symptom testing. And enjoy our lunch symposium in both room A and room B.
In the meeting room, we have a main room, which is room A, where all the plenary lectures are. We also have a room B that will show the exciting online symposium, posters, and nice video shows. We're going to room B. Participants, breakout sessions, you can find in the virtual meeting conference.
Hi, dear audience. I'm the master of the afternoon section, Dr. Su Timu, the Dr. Mu. Welcome back. We are going to start our lunch symposium. Right now, we are in the room A to talk about the RSV. If you have interest to take a look about the pneumonia syndrome, you can switch to room B. If you have any question or comment, please write down in the chat box or chat room. I would like to thank my detailed teacher, the Dr. Pei Zhen Chao, the Dr. Chao, for her help. Okay, let's go on the lunch symposium to talk about the respiratory virus. Welcome the moderator, Professor Xiuling Chen. Professor Chen, please. Thank you.
Okay, thank you. Thank you. Welcome to the lunch symposium for RSV prophylaxis. I have the great honor of introducing Professor Yu Zilin as today's lunch symposium speaker. Professor Lin is a neonatologist at the National Cheng Kung University Hospital in Tainan, Taiwan. He is also the vice president of Taiwan Society of Pediatric Pulmonology and Critical Care Medicine. He earned his MD degree at China Medical University in Taichung, Taiwan. He completed his residency in the neonatology and the pediatric pulmonology fellowship training at University Hospital. He has visited the University of Manitoba Health Science Center in Canada for studying amnion prematurity in 1996. He then became a visitor staff in Stephen Evans' lab for 1 year in 2001. Today, his research interests include maturity, perinatal epidemiology, neonatal network, machine learning, and neonatal respiratory care. Professor Lin has published more than 60 papers so far, so I think he is the perfect speaker for the topic of prophylactic adinvirumab for severe RSV infection among prematurely born infants in Taiwan. As we know, RSV is the leading cause of viral lower respiratory tract infections in infants. 10 infants are at increased risk for hospitalization with RSV. So prophylaxis with adinvirumab is important for premature infants. We are happy to have this special lecture. Please join me in welcome Professor Lin. Please start. Thank you.
Good afternoon. Thank you for your kind introduction. It's my pleasure to be here to share you our experience regarding prophylactic polymyxin for severe RSV infection among premature infants in Taiwan. And This is the outlines. First, we discuss the clinical significance of RSV infection. Let me give you a brief introduction of RSV virus. RSV has single-stranded RNA and with two major surface glycoproteins. The G protein or attachment protein assists with viral adherence to the host cells, and fusion or F proteins are essential for viral penetration into the host cells. And this is a typical chest X-ray of RSV lower respiratory tract infection. You can see there are air trapping, segmental analysis, and increased interstitial marking. Two lung biopsy specimens are presented here. Left side is normal lung. Right side is RSV infected lung. It shows bronchocentric infiltrate with slowing of bronchiolar epithelium and exudate in the lumen composed of dead cells and fibrin. RSV is best known for causing bronchiolitis in young children and also play a role in some certain infant death syndrome, disease, and or apnea. And after RSV infection, it was associated with childhood wheezing. And in the 1960s, administration of formalin inactivated RSV vaccine caused the vaccine-enhanced disease. Globally, it is an important public health problem. It is the leading cause of severe respiratory tract infection in infant and young children throughout the world. And 64 million RSV infections worldwide every year. Infects nearly all children by the age of 2 years, and RSV bronchiolitis spread to cause up to 70% of the infant hospitalization. RSV infection occur in nearly all children by 2 years. 68% of children had their first RSV infection during the first year of life, and the evidence of lower respiratory disease was detected in 21.6%. Primary infection after the first year were less severe, but 97% of them had an RSV infection during their second year. And of these, 6% had an lower respiratory tract disease. RSV immunity is not durable, and reinfections are common throughout the life. Between 50% and 75% of children growth each year have been reinfected each year. Reinfection more than once, even within the same season. Antibody response is not sufficient to prevent subsequent RSV reinfection. And this study showed that the risk of reinfection is inversely proportional to the antibody titer seen with the previous infection. And even subjects with the highest titer of F and the G antibodies still had a 25% chance of being infected. And mortality data suggests that RSV is an important cause of death in childhood from acute lower respiratory tract infection, and it's after pneumococcal pneumonia and Haemophilus influenza type B. About 55% of hospital admission and in hospital deaths due to RSV acute lower respiratory infection occur in children younger than 6 months. So the younger the patient, the more severe the disease. In summary, RSV infection is common in infancy, and reinfection occurs frequently in old children during the first 2 years of life because of incomplete immunity. Next, we talk about infant with high risk for severe RSV disease. This is the summary of my study. In RSV hospitalized children, 12 to 28% of them have a history of prematurity. When comparing with term infants, hospital resource usage is high in all premature infants, including ICU admission, intubation, in-hospital stay, and ICU stay. This is a systemic review regarding RSV infection in children with chronic lung disease who do not receive prophylaxis. Chronic lung disease is a significant independent risk factors for RSV-associated hospitalization. Odds ratio 2.2 to 7.2. And it is also associated with a higher rate of RSV-H than other high-risk group. The reported instance of RSV-H is 12 to 21%, and with a median hospital stay of 4 to 11 days, and associated with the use of mechanical ventilation and ECMO, and a longer duration of mechanical ventilation. So the second summary, children born preterm and with chronic lung disease who do not receive prophylaxis have a higher hospitalization rate, morbidity, and mortality. We then move on to talk about the prophylaxis. And how to prevent RSV infection. We can avoid exposure and risk factors by limiting contact with infected people, remove from daycare and group settings, proper hygiene, frequent hand washing, disinfecting service exposed to infectious secretions, and cohorting hospitalized patients with RSV. And we can promote breastfeeding and also prevent nosocomial RSV infection by proper hygiene, frequent hand washing with alcohol-based hand cleaner, and wearing clean gloves and masks, and cohorting hospitalized patient with RSV. Currently, the only approved preventive treatment for severe RSV disease is palivizumab. It is a monoclonal antibody that binds the F protein of the RSV, so blocking the fusion of infected cells. It is produced by recombinant DNA technology, and it reduces viral activity and cell-to-cell viral transmission. FDA approved this therapy after the IMPACT RSV trial. This trial enrolled 2 groups of preterm infants. The first group just age less than 36 weeks and 6 months younger. The second group are patients with a clinical diagnosis of BPD, requiring ongoing medical treatment, and younger than 24 months of age. They were given monthly doses of 50 milligrams per kilo IM injection of palivizumab during the RSV seasons. In the IMPACT RSV trial, significantly lower RSV hospitalization rate was observed among those who received palivizumab compared to those who received placebo in each of the subgroup. For all infants, there was 55% reduction of RSV hospitalization rate. And in infant less than 32 weeks, 47% reduction. And Corona group, 39%. Infant without Corona is 78%, 32 to 35 weeks, 80%, and 32 to 35 weeks without Corona is 82%. And this graph shows significant reduction, 57% reduction in the palivizumab group in the instance of ICU admission during the hospitalization for RSV infection. The current AAP guideline for RSV prophylaxis is published in 2014. For premature infants with no congenital heart disease, they recommended to provide prophylaxis at the start of RSV season in two groups of preterm infants. The first group with gestation age less than 29 weeks, if they were less than 12 months of age. The second group with gestation age between 29 and 32 weeks, and if they were less than 12 months of age. This is the concept of RSV seasonality, defined as the onset, offset, peak, and duration. The onset week in an area is defined as the first two sequential weeks when the week's percentage of all specimen testing positive for RSV antigen in that area is greater or equal to 10%. The offset is the end of the last two sequential weeks when the weekly percentage of positive antigen exists 10%. And the peak is the week when the percentage of positive RSV test is highest, and the season duration is the period between the onset and offset weeks. This is the RSV epidemiology in the United States. Horizontal axis represent timeline. Vertical axis represent percentage of positive RSV antigen test. This horizontal line here represent 10% positive, and this arrow represent onset, offset, and in between is called the duration of RSV season. Regarding the RSV epidemiology, the exact timing and the duration of RSV seasons vary by region and from year to year. And social and demographic factors such as the population density, pollution, and climate, each might influence the national or regional RSV activity. So the surveillance data can be used to identify RSV activity and coordinate timing of immunoprophylaxis with palivizumab. In the United States and other areas with similar climates, RSV infection occur primarily during fall, winter, and spring. However, Florida has an earlier RSV onset and longer duration than other regions. This is a recent report published in August issue of Pediatrics. In this year, there's a delayed RSV season in the United States during the COVID-19 pandemic. In the past, the RSV season occurred from September to February before the COVID-19 pandemic. So the author suggests that we should extend the monthly preventive palivizumab for infants at risk for severe RSV disease and continue the protection during this unexpected surge. This slide summarizes the conclusions of several clinical reports regarding the children at risk, highest risk for RSV disease, and outlines why these children will be at severe risk for RSV. For example, here, premature births, they have altered airway anatomy and absence of maternal antibody protection. For chronic lung disease, there's bronchial hyperresponsiveness and reduced lung capacity. For congenital heart disease, there's pulmonary vascular hyperresponsiveness and pulmonary hypertension, increased pulmonary blood flow, and also neuromuscular disease and immunodeficiency. And how about the condition in Taiwan? Taiwan is an island located in subtropical region. The epidemiology of RSV infection is different from some other part of the world. The RSV infection occurs throughout the years, and with a peak in spring and fall in northern Taiwan, and without significant seasonality in southern Taiwan. Some studies also found that logic age is the single most important risk factor for RSV-related hospitalization, and most of them occur in the first 5 months after birth. And in this paper, we found that preterm infants were most vulnerable within the 9 months of chronologic age. This slide summarizes the length of stay for LOS for preterm babies in Taiwan. For preterm infant with gestation age less than 29 weeks, their mean LOS is from 2 months to 4 months, and the other group is from 1 month to 3 months. Therefore, a normal RSV preventive protocol for high-risk preterm infants has been proposed by the Taiwan Society of Neonatology and reimbursed by National Health Insurance since December 1, 2010. The protocol consists of 6 IM injection of 50 milligram per kilo of palivizumab given at a monthly interval. For 2 group of infants, infant with gestation age less than 29 weeks, and infant with gestation age between 29 and 35 weeks with chronic lung disease, and the first dose is administered 3 to 5 days before the baby is discharged. And in 2017 April, we changed the criteria to enroll more preterm infants for prophylaxis. So the first group is gestation age less than 31 weeks, and infants with gestation age from 31 to 35 weeks with chronic lung disease. And all of them are younger than, when we give the palivizumab, also another criteria is that they have to be younger than 12 months of age. And we found that this regimen effectively reduced RSV associated hospitalization and all-cause mortality of preterm infants in Taiwan. And admission to ICU and mechanical ventilation will also reduce in infants with just age between 29 and 35 weeks with chronic lung, and the hospital stay and the total hospital cost will also reduce in that group. So the take-home message, globally, RSV is the most frequent cause of a lower respiratory tract infection in children and resulting considerable morbidity and mortality. And prematurity, chronic lung disease are important risk factors for severe RSV infection. And palivizumab prophylaxis reduced the RSV-related hospitalization in high-risk infants during the RSV seasons. And 6 monthly palivizumab prophylaxis reduced the RSV-related hospitalization in subtropical region with prolonged RSV seasons. And thank you for your attention.
Thank you. Thank
Okay,
you for
moderator.
Professor Lin's excellent speech. Any question from the audience? You can write down the questions in the chat box. Okay, maybe I can ask one question. You said that the RSV reinfection occurs frequently in all children during the first 2 years of life. Do you think the 6 monthly palivizumab schedule in Taiwan enough for premature?
Yeah, I think because we know that one of the factors that affect on the severity of RSV infection is the chronologic age. And you know, actually there's a paper from Dr. Xu from Mackay Royal Hospital. They reported that for mature infant, if they have a severe RSV infection, most of them occurred within the 9 months. So they are vulnerable during that period. And the duration for the hospitalization, longer one is for with gestation age less than 29 weeks is 3 months. So we put it together. If we have the 3 months during the hospitalization and 6 months of 6 doses of palivizumab, resulting covering at least 9 months at that group of patients. So that's why that's a good decision for cost benefit balance. So I think it's a good idea to do that. And later on, we analyze those data and then telling the people that actually it's a good strategy to that our country, because we have the prolonged season and we cannot choose at what time let's give the prophylaxis to the children during that period. So that's a good strategy, I think, at present.
Okay. Thank you for your answer. And there is still one question in the chat box. Oh, but the time is up. So we need to end this speech. Okay.
Well, thank you.
Thank you very much.
Okay, thank you. Thank you, speaker, Professor Lin, and moderator, Professor Chen. If any question, you can write down in chat box. Speaker will write answer for you. Okay, let's proceed to the next talk. Welcome the moderator, Professor Zhicheng Chen. Professor Chen, please.
Ladies and gentlemen, it's my great honor to introduce our second speaker, Dr. Qiu Sunnan. Dr. Qiu is a professor and also an attending physician of Department of Pediatrics in National Taiwan University and National Taiwan University Hospital. And then he graduated from National Taiwan University College of Medicine and acquired his PhD at National Taiwan University Institute of Clinical Medicine. He also majored in pediatric cardiology, including infection, susceptibility in congenital heart disease, electrophysiology of pediatrics, and also intervention and imaging of congenital heart disease and pediatrics. And Professor Cho is also a director of Taiwan Society of Pediatric Cardiology, and he also organized many multi-center studies for Taiwan Society of Pediatric Cardiology, including RSV, polyvizumab for respiratory virus infection in congenital heart disease, and pulmonary artery hypertension in congenital heart disease. So Professor Cho is a perfect speaker for this session, and I think he just finished his COVID-19 speech this morning. He's in a very Russian people. So we have the honor to have Professor Cho. Please, Professor Cho.
Thanks for the chairman's introduction, and also thanks the organizing committee and also AstraZeneca to invite me to have a speech here. Today I will talk about the RSV infection and the prevention in infants with congenital heart disease. This is the outline of my speech. First, I will talk about the RSV infection in congenital heart disease. Then we will see the effect of plasmid prophylaxis, and we will special focus on a new subtropical protocol for RSV prevention in congenital heart disease. Then finally, we will see the proposal for subtropical plasmid prophylaxis guideline. Let's see the RSV infection in congenital heart disease. Respiratory syncytial virus (RSV) is a single-strain RNA virus with envelope. It belongs to Paramyxoviridia. It has 11 proteins, with 3 proteins will help virus to bind to the host cell receptor. The F protein, fusion protein, will mediate the fusion of cell and the viral membrane. This protein is relatively constant and is always the target of the vaccine and the automonoclonal antibody. Through the G protein and F protein, the RSV will enter and duplicate in our nasal cavity. It will then invade the lower respiratory tract, which may cause the bronchiolitis and the pneumonia. It often invades the infant and toddlers because they have narrow airway and an immature immune system. RSV is an important cause of death in children. It is the third most important cause of death in infants from the WHO report, and it is also the primary viral cause of death in infants younger than 1 year of age. It causes more than 30 million cases annually and causes more than 60,000 to 200,000 cases of death annually in the whole world. In Taiwan, it is also the leading cause of respiratory tract infection in children less than 5 years of age. We can see it causes more than half of the case of the lower respiratory tract infection. In pediatric population, for patients with chronic lung disease, congenital heart disease, and prematurity, they have a especially high risk of RSV hospitalization. From this report from the United States, we can see the bronchopulmonary dysplasia is the leading risk factor, followed by congenital heart disease. This is the health insurance nationwide database study from Taiwan from 2005 to 2010. With more than 8,000 congenital heart disease patients, we can see the RSV hospitalization rate is especially high in patients with cyanotic and the hemodynamic significant cyanotic congenital heart disease, and the risk is especially higher for patients younger than 1 year of age. Not only the hospitalization rate, but the symptoms are also more severe in these congenital heart disease patients. From this figure, the hospitalization deaths and the hospitalization costs are all higher in patients with cyanotic congenital heart disease and the hemodynamic significant cyanotic congenital heart disease. The ICU admission rate, ventilator support rate, and also mortality are all higher in cyanotic congenital heart disease, followed by the hemodynamic cyanotic congenital heart disease. From this study, the age is an important risk factor of RSV infection in congenital heart disease patients. For the age younger than 1 year of age, the RSV infection rate is significantly higher both in cyanotic and cyanotic conjugal heart disease. Then we will talk about the effect of pyruvate prophylaxis. Then let's see how to prevent RSV infection. The general prevention is very important. We have to avoid second-hand smoke to decrease RSV infection rate, and the breast milk feeding can increase immunity and decrease infection rate and severity. Vaccination is always an important tool to prevent virus infection. Like COVID-19, we use the vaccine to decrease the transmission and also infection rate. However, there is still no effective pediatric vaccine for RSV prevention yet. There are some new vaccines for maternal immunization during pregnancy and to see if it can prevent the RSV infection for neonates after birth. We will discuss it later. So till now, the passive immunization is still the most important tool for RSV prevention. We give the patient monoclonal antibody, the pembrolizumab, and it can use to prevent RSV or respiratory infection in high-risk patients. As early as 2003, there is a large multi-center double-blind clinical trial in Europe and Northern America. For more than 1,200 patients, hemodynamic significant conjugal heart disease patients less than 2 years of age. They found the pyruvate prophylaxis will reduce hospitalization rate in this young age patient. We can see the hospitalization rate will decrease by 45%. The days of hospitalization will decrease by 56%, and the oxygen therapy days will decrease by 73%. So, from this study, we can see the pyruvate prophylaxis is very useful for the prevention of the RSV infection in hemodynamic significant conjugal heart disease. Because of the evidence from this multi-center study, the AAP guideline now suggests the children younger than 1 year of age with hemodynamic significant CHD should receive pyruvate prophylaxis in this patient. They suggest the cyanotic conjugal heart disease with heart failure symptoms or require cardiac surgery should receive the pyruvate prophylaxis. For the patient with cyanotic CHD, the decision of pyruvate prophylaxis depends on the pediatric cardiology suggestion. For children receiving prophylaxis and the receiving operation, 1 more dose of pyruvate should be considered after cardiac bypass. They suggest total 5 doses of the pyruvate during RSV season should be given in these high-risk patients. However, the severity of RSV infection differs a lot in different countries. This is the RSV cases in the United States. We can see there is a very clear RSV season beginning at around September till March in every year. However, in our country, it is in the subtropical area. We can see the RSV cases we have RSV cases all around the year, and the RSV peak in March, April, May, and also peak in June, August, September, and October. So we don't have a clear RSV season. Because most of the audience is from the Asia Pacific area and many of the audience from the Southeast Asia, so the RSV season may be not very obvious like in our country. So we have provided our experience, which is a Taiwan policy of pyruvate prophylaxis. We suggest the pyruvate prophylaxis for all infants less than 1 year old with hemodynamic significant conjugal heart disease, which is defined as the all cyanotic conjugal heart disease before total coagulation or after total coagulation with residual cyanosis or heart failure. Or for patients with a cyanotic conjugal heart disease with heart failure, the definition of heart failure to fulfill the two of the following three statements: the failure to drive significant cardiomegaly and more than 2 anti-conjunctive medication needed. We will give the patient monthly pyrumab injection since the diagnosis till total correction, and 1 more dose before discharge from cardiopulmonary bypass surgery. The maximum dose of pyrumab injection is 6 doses. We then perform a multi-center study to see if this novel pyrumab prophylaxis protocol have efficacy in preventing ICV infection in hemodynamic congenital heart disease patients. This multi-center study is from the northern part, middle part, and southern part of Taiwan, and between 2010 to 2016. We use the study group and also the historical control, and we divided it into 3 eras: the synergies era, transitional era, and the synergies era. This is a clinical characteristic. We have formed the propensity score match, and we can see after match, all the clinical parameters was similar between the two groups. Then let's see our results. Under this novel pyrumab prophylaxis protocol, compared to the control group, the ICV hospitalization rate decreased around 50% after propensity score match. The ICU admission rate also decreased by 57%. We also see separately for the cyanotic and the cyanotic congenital heart disease. For cyanotic hemodynamic significant congenital heart disease, the pyrumab prophylaxis will decrease hospitalization rate around 35%, and for cyanotic congenital heart disease, the ICV hospitalization rate decreased by 65% after propensity score match. This is the Kaplan-Meier ICV hospitalization-free survival curve. We can see after pyrumab prophylaxis, the ICV hospitalization rate decreased more than half of patients. And also compare these 3 areas, we can see the ICV hospitalization rate decreased dramatically after pyrumab prophylaxis. Then we try to find the cost effectiveness of this subtropical guideline. The mean dosage of pyrumab is 3.9 doses in the current guideline, which is less than 5 doses in the AAP guideline for countries in temperate zone. However, the prevention of ICV hospitalization is as effective in the current guideline. It decreased the ICV-related hospitalization by 49% compared to the 45% in the multi-center study. So I will make a brief summary here. Using this novel pyrumab protocol, the ICV-associated hospitalization rate and severity reduced significantly in hemodynamic significant congenital heart disease patients in the subtropical area. And compared to previous multi-center study, the efficacy is comparable, and it is also effective in cyanotic congenital heart disease patients. So, this subtropical pyrumab prophylaxis protocol may be applied to the area with no previous ICV season, like tropical and the subtropical area. Finally, I will talk about the appraisal of subtropical pyrumab prophylaxis guideline. So, after 5 years of the subtropical guideline of the pyrumab prophylaxis, we try to find out if there is any other revision necessary for this subtropical protocol. This is a single-center study for more than 700 patients receiving a subtropical guideline for pyrumab prophylaxis in hemodynamic significant congenital heart disease. We can see in these 772 patients, 42 patients still have ICV infection, and we try to find if any risk factor is associated with the ICV infection. We can see the associated anomaly, especially genetic syndrome and the lung airway anomaly, is more common in the ICV infection group. On the current study, we can see the most important cause of RSV-related application is that the patient not fully vaccination criteria, around 70% of the patient. This means the current protocol guidelines still have some shortage. Because after the patient receiving total correction, they are no longer fulfilling the criteria of the pyruvate prophylaxis. So there may be some patients still at high risk. On this figure, we can see the associated anomaly has significantly higher RSV-associated hospitalization rate compared to those without, both in the age below 1 year and 1 to 2 years of age. When we consider a subgroup of associated anomaly, we can see the genetic syndrome had higher RSV-associated hospitalization rate. The patient with down airway abnormality, especially below 1 year of age, had higher RSV-associated hospitalization rate. Not only the increased RSV hospitalization rate, but also the increased RSV severity. We can see the ICU admission rate, the intubation rate is all higher in patients with associated anomaly. And for genetic syndrome and for the down airway abnormality, the ICU admission rate and the intubation rate is also higher. So we may suggest the patient with associated anomaly, especially genetic syndrome or down airway abnormality, is at especially high risk and should receive more doses of pyruvate prophylaxis under recent guidelines. The mean doses of pyruvate is around 3.3 in our cohort. Compare those with associated abnormality and those without. The mean dose of pyruvate differs significantly, both in the whole group and in the subgroup. These patients are at especially high risk of RSV hospitalization, but we didn't give them extra dose. So further guideline revision may be necessary to give them further prevention of RSV infection. Here I will make a brief summary about this study. On this study, the patient with associated abnormality, especially genetic syndrome and down airway abnormality, carry especially high risk of RSV infection in hemodynamic significant congenital heart disease patients. Further subtopical pyruvate prophylaxis guideline adjustment may be necessary, and the extra doses may be necessary for a patient with associated abnormality to give them extra prophylaxis. Then let's see the RSV prevention strategy in the future. There are many new antiviral medication, vaccination, and immunoprophylaxis for RSV prevention under investigation. For the antiviral treatment, the only market-approved drug is ribavirin, but its use is still controversial. Some new drugs has been developed, but it's now in phase 2 trial. For the vaccination, there are two targets. Some of the vaccine target on the maternal, and some of the vaccine target on the pediatric infant. The only vaccine now under phase 3 study is race-based. We will discuss it later. For the immunoprophylaxis, there is a monoclonal antibody. We have the Synagis, which is now under market approved, and the nirsevimab, it is now under phase 3 trial. Okay, let's see the new monoclonal antibody for immunoprophylaxis and the maternal vaccination under investigation now. The nirsevimab, it is now under phase 3 trial. It is targeted on the preterm and high-risk children. And the Merck has a new vaccine which is under phase 1-2 trial. It is targeted on preterm infant. The ResVax, which is the maternal vaccination and try to provide prophylaxis for the neonate and the young infant. It has completed its phase 3 trial. However, it didn't meet primary endpoint. Then let's see a comparison of the maternal immunization and the infant monoclonal antibody use. They all belong to passive immunization. For the maternal vaccination, we give the pregnant woman a single dose vaccination in the third trimester, and the mother will induce a maternal monoclonal antibody. The antibody will transmit through placenta to the newborn and to a fetus, and after birth, they will have a maternal antibody in the blood. However, the hepatitis is not very long, so their protection will decrease around 2 to 3 months later. For the monoclonal antibody, has been used widely now. However, the pyrumab still has some shortage because it has short half-life, so we have to give the patient monthly injection. Now, the nirsevimab has prolonged half-life, and we can give the patient only 1 to 2 doses, and they will have the 6 months protection. And about the pediatric vaccine, there are alternative vaccine, chimeric vaccine, and the vector-based vaccine. However, they are all now at the phase 1 to 2 trial. So we have to see whether it can provide adequate prevention efficacy in the patient, in these high-risk patients. So I will make a brief conclusion here. The RSV infection is an important cause of admission for low respiratory infection in congenital heart disease patients, and carry high mortality rate still, especially in the development country. And the severity and the hospitalization rate is especially high for those with under 90s, especially congenital heart disease. Thus, pyrumab prophylaxis monthly injection has proved its efficacy to reduce hospitalization rate and severity. And the subtropical guideline proposed by Taiwan has proved its efficacy in subtropical area through multi-center study. And we may apply this protocol to the country with no previous RSV season. And the further guideline adjustment with extra doses for those with associated abnormality may be necessary. Thank you for your attention.
Thank you very much, Professor Cho, for your excellent speech. It's very informative. And now I would like to invite our audience, if there is any question, please. I saw in the chat board, there are 2 questions. Yes, please. Question 1 is from Professor Lin Yuzhi.
So moderator, Professor Chen, you have to explain or to say what is the question?
Yes, okay. The question from Professor Lin is that he's asking that the expense of RSV provided by the National Health Insurance and is very expensive. It's very expensive, and so from the study, it shows that the preterm is most valuable in the first 9 months, and the duration of hospitalization is less than 3 months in these high-risk patients. So is this why we provide 6 months doses for these patients? So Professor Cho, do you have any comment for this question?
I think this is all about the cost and benefit because the pyrumab is still relatively expensive and it needs the monthly injection. So in the AP guideline in the United States and the other Western countries, they suggest 6 doses during the RSV season. And in our country, because there is no clear RSV season, but when we use the monthly injection for the 12 months, it will be double the cost. So we provide a modified guideline to provide the RSV pyruvate prophylaxis at especially high-risk patients, and it will decrease our cost and also provide adequate immune prophylaxis for these high-risk patients. So I think this is the issue of cost and benefit. Maybe if someday the pyruvate is very cheap, then we can provide maybe till 2 years old. It is also okay.
All right, thank you very much, Professor Cho. Is there any question for Professor Cho? If not, I have one question for Professor Cho. I think this type of question goes to any type of vaccine. So after we giving regular giving to the RSV vaccine to those hemodynamic compromised congenital heart disease children, are we going to change any lower lung infection microorganism panel or virus infection panel during this type during the age?
I think it is a very difficult question because there is no such study about the virus or bacteria spectrum change after the pyruvate prophylaxis. But we can know that after the prophylaxis, the RSV spread and RSV infection and the RSV infection rate will decrease dramatically. And maybe some may say if there is any virus strain change after the immunoprophylaxis, fortunately, because the pyruvate is still target on the F protein, it is relatively constant. So it will not, after prophylaxis, all of the strain can be prophylaxis now. So still till now, there is no breakthrough, there's still no virus strain which is resistant to the pyruvate. So I think this may need further study about this issue.
Thank you very much. I think due to our limited of time, yeah, we have to close this session. Thank you again for your excellent speech, Professor Cho. Thank you.
Thank you. Thank you.
Okay. Thank you, the speaker, Professor Cho, and moderator, Professor Chen. Let's take a break. Welcome back 5 minutes later. Enjoy yourself in professional dessert. Back in 5 minutes later. Remember back on PM 1:30. Thank you.